So moving on to the next talk, which is a pediatric anesthesia. And as you'll know, giving anesthesia for pediatric patient is a unique, definitely challenging and different than adult population. Pediatric patient can have a special physiological, anatomical consideration when it comes to airways. In fact, they have the potential to desat very rapidly during the induction of anesthesia. Endotracheal tubes. What about endotracheal tubes? What are the situations and benefits of using cuffed endotracheal tubes for pediatric patients? Pediatric patients also present a difficult challenge when it comes to regional anesthesia, not only this, but also getting an IV access. To discuss all these issues, in our next talk titled Tips and Tricks for Pediatric Anesthesia, and I have the pleasure to reintroduce our next speaker. She's a professor at the Department of Anesthesiology at the University of Texas Medical School at Houston. She has served for 6 years as a program director for Pediatric Anesthesia Fellowship at the same university. She's the present chief pediatric anesthesia at the Children's Memorial Hermann Hospital, Houston, and also at the same hospital, she's the present director for pediatric pain service. Please welcome with me Professor Maria Matuszczak.
Thank you for the very kind introduction, and good afternoon to everybody. So I chose some little topics that are deep in my heart for pediatric anesthesia. This morning I showed this picture already where I work, and so this afternoon it's about rapid sequence induction in children. I want to talk about and pass some message on about passive oxygenation during difficult intubation, management of children with obstructive sleep apnea, difficult IV access, and the benefit of cuffed ET tubes. These are all topics that have been in the pediatric anesthesia discussion for the last several years. And actually this paper from Martin Jör from Switzerland, Anesthesia for the Child with a Full Stomach, kind of summarized the problem we have with children when they need a rapid sequence induction, specifically the very small children. You know, you all know the scenario. You're supposed to not ventilate for the rapid sequence induction. You give your IV medication. Patient pre-oxygenation, by the way, in a little child who is jumping around on your OR table is not very successful in generally. So then somebody is pushing cricoid pressure. How much, not how much, you actually have no way of saying. Then the child is apneic for some time, and then you have your first look, or your resident have the first look, and what happened then? He can't intubate, your saturation starts to drop, boop, 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 and then you get panic, and then you start ventilating the child with a full stomach because you want to bring the saturation up, and that's when your child aspirates. So there has been a talk between pediatric anesthesiologists to modify this way of doing the classic rapid sequence induction. And Dr. Jör here from Switzerland says, hopefully the chapters of RSI in children will be rewritten in the future editions of anesthesia textbook, and I am supporting this idea, and they should be. So shortly after that, there was a publication also from Switzerland, surprisingly, about a classic, about actually a modified or controlled, they call it a controlled rapid sequence induction. And what it is actually, you induce your child and you give the medication, and instead of doing cricoid pressure and apnea, you put the valve on your machine to 10, and then you very gently continue mask ventilating the child until your muscle relaxants and your anesthetic has place and take, and you have no desaturation, you do very gentle ventilation, as I said, and then you intubate. So you are sure the child is not reacting anymore because you started too early to intubate the child. And this is actually the plan of what we call now the controlled rapid sequence induction. And the group from Peter Weiss from Switzerland, they have actually developed a protocol on how everybody is supposed to do these controlled rapid sequence in their department. And they looked back retrospectively about 1,000 children who all had this controlled rapid sequence induction, and to see were there any problems with this different way of doing the rapid sequence induction. And they found moderate hypoxemia and very little severe hypoxemia, only 3 cases in these 1,000 patients. No bradycardia, no hypotension. There was 1 gastric regurgitation with no pulmonary aspiration that they could find. There were 2 difficult expected intubations and 3 unexpected. And there was no silent aspiration. So they could actually show that this way of doing rapid sequence induction, even if you have a full stomach, is fairly safe. So this is the protocol. It's a big slide. You can't really read anything, but it describes the protocol that everybody is supposed to follow in this department. This is quite difficult to implement in the United States because everybody is scared about the legal litigations when you have an aspiration and you have not followed the RSI. So some of the patients who had really critical abdominal pressures, they actually placed a gastric tube and suctioned the tube while they were preparing the child and while they were starting the anesthetic. And these are just 76 out of the 1,000 had an intestinal obstruction, and they were actually actively vomiting before they came in the OR. And in this group is also the pyloromyotomy kids that are generally at high risk for nausea vomiting. So then a little bit after that from England came another publication, also the classic, to modify the classic rapid sequence induction. And they looked at their children and compared the controlled versus the classic, and they had no difference. They found that the controlled is much safer, and that the classic way has no place in the pediatric population. So as a conclusion for this first topic, and what is important to avoid aspiration is also to let the anesthesia become deep enough and not go too fast. And the fact that you leave a little baby in apnea will trigger that you don't want the saturation to drop too much, and so most people start the intubation too early, and that causes the aspiration. So on top of this, we all do cricoid pressure even in adults, and it has never been shown to be effective. So this is really, I'm convinced this is the best thing we do for children, and we are right now looking in our place, all our pyloromyotomies, children at high risk for aspiration. And we have found that since we changed to the controlled rapid sequence induction, and these data are not published yet, we had no difference in complications. Okay, next topic, passive oxygenation. That's another topic in my that is dear to my heart. There is a group of pediatric anesthesiologists in actually several countries throughout the world, and 12 hospitals in the United States, who prospectively collect data about difficult intubation in children. which successful device, how often did you try to intubate, how often did you have hypoxemia, what were the complications of these children, and I am actually showing you here a little video that summarized what we found in our... The sound?
We created an online registry to improve their care across 14 children's hospitals all over the world. Unfortunately, 20% of these children have complications. In 1,000 cases, 13 children's hearts stopped beating, and many children had a low oxygen level. Some children had more than 20 tries to intubate, and we found that children who had more than 2 tries had more complications. You can help these children by giving oxygen to every patient during intubation. Thank you for caring, and now here are some ways to give oxygen when you are putting in the breathing tube.
So what we found on the first 1,000 children, there were 5 deaths due to difficult intubation. That is an incredibly high number, and that actually has scared a lot of us. And hypoxia is one event or one first start to go down this pathway, and that's why we as a group have promoting the idea to, as soon as you realize that the intubation can be difficult, to continue passive oxygenation. Whether the child is breathing spontaneously, then he breathes through a nasal cannula. You still can do mask ventilation with it if you know how to do correct mask ventilation. You can use the little nasal trumpet that you saw on the picture, and if you put an ET tube connector in there, you can connect it to your circuit while you are trying to re-intubate or preparing other devices that will help you for the intubation. So this data was published in the Lancet last year, and I think it's a starting point to change the way how we treat children when they are difficult to intubate. They do not have a lot of reserve, you all know this, and a newborn actually starts the path through desaturation after 6 seconds. So there is no way that when you do multiple attempts, you will not have hypoxemia. Okay, so the next topic is obstructive sleep apnea. We have more and more obesity in all over the world, in all countries. And it's really epidemic in the United States, and there is an increase of children with OSA. We have children that are 10 years old and they are 100 kilos, but you don't even need to go that far in order to have sleep apnea. These children are at increased risk to die after anesthesia, and specifically when opioids are used. And there was a paper published 3 years ago by Charles Coté, deaths or neurologic injuries after tonsillectomy in children, with the focus on obstructive sleep apnea. Houston, we have a problem, yes. And we have a problem, definitely. We have not been giving opioids for many years to children because everybody thought they don't need opioids. Now we have been to the opposite side and giving him probably too much opioids. And that's the other side of it, is how do we manage pain in these children. So what did Coté do? He surveyed all members of the Society of Pediatric Anesthesia and asked them about adverse events in children undergoing tonsillectomy. And just on a side mark, this is not limited to tonsillectomy. It has to do with obesity, obstructive sleep apnea, and the use of opioids. So, but what he found, 111 cases were included in the final analysis. And you can see 70% the cases of death and permanent neurologic injuries from these 111. 57% children were at risk for OSA out of these 116, and 10 deaths or neurologic injury occurred at home, 2 in the PACU, and 3 on the ward within 24 hours of surgery. So they actually die everywhere, not only at home. And I think we have to be aware that we should avoid opioids. We should know that children who have obstructive sleep apnea, due to their hypoxemia, they are more sensitive to opioids. So the opioid use should be reduced or avoided. And we must be aware also of the use of codeine. I don't know if you use codeine in this country. But there are rapid metabolizer, there are non-metabolizer, and there are medium metabolizer. And the rapid metabolizer actually metabolize so fast that your concentration of morphine in the blood is doubled, and put these children at risk for a respiratory arrest. So we should not use this at all. So I have 5 minutes left, so I'm going to go a little faster again. Our practice is actually for TNAs now to not use opioids at all. We induce them with sevoflurane, place an IV, give propofol for induction. We do not paralyze normally our TNAs. We then give ketamine, 0.5 milligram per kilo, and dexmedetomidine, 0.5 micrograms per kilo as a bolus. We continue ventilation with sevoflurane only at 1%, and they do perfectly well. They don't need any opioids during the procedure. Ketamine takes care of the analgesia. And when they are in recovery room, they receive acetaminophen and ibuprofen. And our ENT surgeons do not write for any opioids for home. So they can take alternating ibuprofen 10 milligrams per kilo and acetaminophen 15 milligrams per kilo. And we tell them to do this at home scheduled, so they're not behind on pain medication. Difficult IV access. I think we all struggle with this from time to time. We have had complaints from parents who were telling us, okay, my child came out and had 25 sticks all over the body. So we have now implemented a protocol in our department that you do 3 sticks. After the third sticks, you go to ultrasound. And if, even with the ultrasound, you cannot get an IV, then the discussion comes, what is next? Sometimes we have done short procedures without IVs, just on sevoflurane. And depending on what you do, you can do Toradol, ketorolac IM for pain medication, or give them acetaminophen in the PACU. Or the discussion then, if it's a bigger procedure, is do we place any type of central lines. We try to avoid that. If it's a short procedure, you can very well go to the intraossei, and that has been used in the emergency departments and has been reserved for emergencies. But before you spend an hour or an hour and a half under anesthesia to find an IV, it may be reasonable and it's safe. We don't have real data yet, but we have started to implement this. To really look why not an intraossei IV or fluid access. And so there have been studies to compare the complications of these roads. Okay, good. Just an image of how this works and an image on how you follow with the ultrasound your line placement. Do I have time for the last topic real fast? Okay. So cuffed ET tubes in the last several years, more and more cuffed ET tubes have been used. There has been a big discussion, is there an age limit? Again, the literature shows that it's beneficial actually to use a cuffed ET tube. You have less re-intubation for improper size. You have also less re-intubation specifically in the ICU. You can use better controlled ventilation. So there are a lot of benefits with cuffed ET tubes. But there's one thing you have to think of. Your cuff, you can not just inflate the cuff, you need to measure the cuff pressure. That is important. For this to be beneficial, your cuff pressure should not be over 25. We have, when we started using ET tubes, cuffed ET tubes in the pediatric ORs, we decided to have a manometer at every anesthesia machine. And so we don't even inflate with the syringe, we inflate with the manometer and make sure we're not over-encuffing. This is an image of a child with an ET tube with a wildly over-inflated cuff, as you can see. Of course, this causes damage is even after a short time intubation. We had a patient who was resuscitated outside the hospital, intubated by the transport team who brought the child in with the helicopter, and he had actually a tracheal rupture from the overinflated cuff, because it was adult stream. They put the entire 10 cc syringe on this, inflated the cuff, and the trachea ruptured, and he needed to be put on ECMO for the trachea to be repaired. Okay, so these are, I think I'm good. Thank you for listening.